So the heart is a pretty important organ. Yeah, we're going to go with that. I'm going to do 3 different talks on the heart. As always, we're going to try to keep to the basics, try to give you enough stuff that is easy enough to digest. There'll be a lot more to learn later on, obviously. So let's start with something that we see fairly often. You're in the emergency room, and a 62-year-old woman comes in with some mild substernal chest pain. She got it after she was eating lunch. It kind of shoots to her jaw and her arm. She gets a little bit of a choking sensation, but she's a little bit short of breath. She's a little sweaty. So in women, of course, they present atypically. Many women present even without any chest pain. They'll usually present with shortness of breath. So no matter what, when a patient like this comes in, we have to work them up for heart issues. So we look at her, we take her vital signs. She's a bit tachycardic. She's got a high blood pressure. She is satting just fine though. She says her pain's about 6 out of 10. She described it as mild, but now she says 6 out of 10. So we're having to sort that out. Now, oxygen by some accounts is a medication. But oxygen for chest pain is actually pretty controversial. For years and years and years, when anybody had chest pain, we stuck oxygen on them. We probably still do if we don't have an O2 sat monitor. But once we know what their O2 sat is, the general feeling is that you probably don't need to give them oxygen. There's arguments about oxidative stress. To be honest with you, I don't even think it's a real thing, but there's many people that believe in it. And no matter what, the outcomes are sort of not really any better with oxygen than without, and some argue maybe worse. The American College of Cardiology says that the issue is not completely settled. It's not wrong to put oxygen on, but it's also not necessary. 12-lead EKG, looking for signs of a heart attack. More sensitive than that is actually the cardiac enzymes, the troponin. Blood gases if you think the person isn't satting well enough. A blood count, a chemistry panel. Nitroglycerine will improve the blood flow to the heart. And again, morphine for pain is actually getting more and more controversial because, again, there's some evidence that seems to suggest the outcomes are not quite as good. You will still, however, see it used. So what else about Betty? Well, she's a type 2 diabetic. Note that it's type 2 in an Arabic numeral, not Roman numerals. Roman numerals have been out for about 20 years, although it is a thing that doesn't seem to die because there's so many older people that put type 2 with Roman numerals for many years. But the more correct, more up-to-date thing to do is to put the Arabic numeral. She does have a history of angina. Angina just means chest pain. Angina just means pain, actually, but angina pectoris, which is chest pain, is usually what we're referring to when we say a patient has angina or angina. Either pronunciation is correct. She's got a history of hypertension, so she's on a mild diuretic for that. She's got a history of smoking for a pack and a half a day for at least 45 pack years. She actually quit a year or so ago, and she does have a family history of her father having a heart attack at a relatively young age. As we noted, she was on a little bit of a mild diuretic. The current hypertension guidelines suggest that that's one of the options. That's what she's on. And because thiazide diuretics work on the distal tubule, they wash out a little bit of potassium. They also wash out sodium and water, so you need to keep an eye on various laboratory tests. She's also on some glipizide. Glipizide is a diabetes medicine. Usually we start with metformin, but she couldn't tolerate the metformin due to the diarrhea. And basically the glipizide stimulates the pancreas to form insulin. You'll still see it used fairly often. There is a movement to try to decrease the use of glipizide because it causes some weight gain. But unfortunately, a lot of the other medicines are really expensive and the insurance companies resist letting you use them. Nitroglycerin is a nitrate. It is a vasodilator. It works directly on the blood vessels and opens them up. It opens up the coronary arteries and improves blood flow. It decreases preload, decreases the stress on the heart. The only problem with nitroglycerin is that it'll really drop the blood pressure in some patients. Some people are very cautious in using it because if you drop the blood pressure and you don't have an intravenous in, you don't have a whole lot of options to bring their blood pressure back up. So something to keep in mind and something to think about before you administer nitroglycerin. So the majority of patients, if they do have evidence of an acute anterior MI, so-called STEMI, which is an ST segment elevation MI, they'll go to the cath lab. The problem is only about 35 to 40% of hospitals have a cath lab. Some hospitals are close enough that they can transfer somebody to the cath lab, but some hospitals still have to rely on thrombolytics, medicines that break down clots. They're used a lot more for stroke now because there's not really a cath lab for that. In most places, there are some places that can actually extract the clots, but the vast majority of places will use this clot buster medication. And then how do you keep the clot from forming again or allow the body to dissolve it further? Heparin, anticoagulations, and aspirin and Brilinta are often given after a heart attack to decrease the risk of another clot forming. So Betty's in the ICU or CCU, cardiac care unit, depending on the hospital's classification system. In Maine, we often refer to it as SCU, which is special care unit. So at Maine Med, patients don't go to the ICU, they go to SCU. She has a little bit of a low-grade temp maybe, not really enough to call it a fever. She's a little bit tachycardic still. Blood pressure is still fairly high. She's got some crackles. She's got an S4, and her EKG shows that she is evolving an MI. So she's put on a nitroglycerin drip. She's usually using a heparin drip as well. There is a new medicine that I'm not going to really talk about because it is pretty new and pretty specialized at this point, but those of you that are highly motivated may want to look up bivalirudin. Now the heparin drip is ordered at 12 units per kilogram per hour. Most commonly, the prescriber will figure out exactly what the dose is going to be. In this case, it's very common for the prescriber to order it by kilograms, units per kilogram per hour, and leave it up to the nursing staff and pharmacy to figure this out. So this is something that you may end up doing. D5.25 saline, and so what's happening? There's ischemia. Ischemia means decreased blood flow. Injury means there's actually some strain to the cells. And infarct means there's actually a complete blockage where there's been some cell death. We worry that there will be an infarct. When you have an infarct, we call it a myocardial infarction, also known as a heart attack. But right now, we're not sure that those cells are actually dead. We know they've got decreased blood flow. We know they're showing strain, but we want to restore the blood flow if we possibly can. So obviously, this is more of a pharmacology course, but to just review what we're trying to restore the blood flow to, the left main artery is the coronary artery that the blood flow comes down. The left anterior descending is the one that supports the left ventricle more. The right coronary artery actually supports the right ventricle and the inferior part of the heart, which is why if you have a right ventricular MI, you'll see inferior changes on the EKG, and then the circumflex goes around the outside. If there's a blockage in the left main right here, this is what's sometimes referred to as the widowmaker, just because basically you've got the whole lower part of the heart that's just dead. If there's blockages further down, obviously there's less cell death, etc. So if there's a clot, what do we do? Well, as we say, we can take them to the cath lab, and that opens up the area. The interesting thing about percutaneous interventions, or PCIs, is that in an elective situation where you find this sort of routinely on a stress test or whatever, the quality of life of a patient will often increase, but the death rates won't go down. In an acute MI, the death rates go down by about 17–18%. So there is definite benefit. Thrombolytics don't have quite as good outcomes as the cath lab, but unfortunately not every hospital has a cath lab and can get somebody to the cath lab in the allotted time. And the other thing, of course, is that we use anticoagulants to try to prevent clotting down the road. So how do we know if there's been a heart attack? Obviously, the EKG shows changes. We talked about an ST segment elevation. Obviously, you'll learn about that later on when you learn about EKGs. And we also see that enzymes are leaking out of the cells, troponin and creatinine kinase, especially the M band, which is the one that comes from the heart. The other thing to remember is that there's electrical conduction to the heart. All heart impulses are supposed to start in the SA node. They don't always, but when they don't, we refer to that as ectopy. Sometimes they start in another part of the atrium. Sometimes they start in multiple parts of the atrium. When that happens, that could either be a wandering atrial pacemaker, or it could be even atrial fibrillation if they're firing one after another. Then the impulse travels down into the AV node. The AV node then distributes it down through the bundle branches into the ventricles. Heart attacks will interfere with this, not infrequently, but there's other things that can interfere with it as well. Other things that can interfere with it are certain medications can cause ectopy. High potassium levels, although be very careful when a high potassium level comes back. The first thing to think of is lab error, just because if the blood hemolyzes, then the potassium will leak out of the red blood cells and will give you an artificial elevation. But if you've got a truly high potassium level, you worry that they're going to have some ectopy. Alcohol can do it. Idiopathic, which means we don't know. Thyroid disease can do it. Anything that irritates the heart. If it's an MI, that means that there's probably going to be true permanent muscle damage, and eventually we want the rest of the heart to get stronger. If someone's had an MI, we'll put them on beta blockers to keep the rate from getting too high, basically to decrease the heart from having excess oxygen demands that it can't meet. An ACE inhibitor will prevent left ventricular remodeling. Statins will lower the risk of another heart attack. And then anticoagulants, longer term, such as aspirin and Brilinta, will also decrease the risk of a second heart attack. You may have seen in the news recently that the Aspirin study was done and basically said that there was not a benefit for aspirin. Two things to remember with that. One is that was for primary prevention, not secondary prevention. Secondary prevention is for people after a heart attack. The other thing is to remember that that study did not include diabetics. It very specifically excluded diabetics. So you can't really assume that. There was another study that was done with diabetics called the Ascend study, which did seem to suggest that there might be a mild benefit for aspirin, although that was less than impressive either as far as the benefits of aspirin, but it is not something that was strong enough to suggest taking people off aspirin. Now, when a person has a dysrhythmia or arrhythmia, arrhythmia truly means no rhythm, so I don't usually use that term. I say dysrhythmia, which is a bad rhythm, because bad rhythm is better than no rhythm. Then there's various medicines that we can use. Now, classification 2 and classification 4 are just beta blockers and calcium blockers. So we really don't refer to those as 1s or 4s. With the regular anti-dysrhythmic medicines, ones are very frequently referred to that way. There's 1Cs, 1Es, those kinds of things. And those have very specific factors that you will learn. The potassium blockers are usually referred to as, classification 3. Amiodarone is the most common of those. Amiodarone is a medicine that can be pretty toxic, but is also very good at decreasing dysrhythmias. So it's very frequently used, especially in the acute phase. Some people use it long term to decrease dysrhythmias like atrial fibrillation and others. But it is something that, as I say, is a pretty a big gun medicine which has a lot of side effects. The classification 5, which are the AV node slowers, such as digoxin, are not used very often anymore. So let's get back to Betty. So she had all of these symptoms that we talked about. These were her vitals. And so what are we going to do? We're probably not going to give her oxygen. We need to do a 12-lead EKG to make sure she hasn't had a STEMI. We're going to check her troponin to see if she's in fact had evidence of cellular injury / death. Probably won't do blood gases with a 97% O2 sat. We will do a blood count and a chemistry panel to see if there's anything else going on that we need to do. With her level of pain, we probably wouldn't use morphine. We might try a single nitro under her tongue. So we did maintain her oxygen to her myocardium. Her EKG was returning to baseline after going to the cath lab. She did have a little bump in her troponin, and she didn't have any dysrhythmias other than a few PVCs. So drugs of the week. All of these are used for people with heart attacks or ischemic events. So look those up, talk about them on Blackboard, and we'll talk some more if you have other questions.